outcomes in our patients, and the sicker the patient, I think that everybody hears me. The sicker the patient, the better, because of course the outcome of ablation is a little lower. It's worse in more patients that are more sick. But on the other hand, the effect of the ablation in those patients is more pronounced than in the relatively young person without comorbidities who doesn't have stroke, who doesn't have heart failure, or anything. So let's move forward. We are talking today about those two parts: avoid stroke and reduce symptoms. So generally, the very important thing, and I cannot stress it enough, is that all the things I will be showing you today are on top of oral anticoagulation. End of the story. And every patient with heart failure, with atrial fibrillation at elevated risk of stroke, whether it's by Chadwas score, whether it's atria, ABC stroke, other stroke risk scales, they have to be anticoagulated. And then on top of this, we have another things to do. So the other thing is that atrial fibrillation, it's not only about symptoms, because atrial fibrillation that is asymptomatic kills patients, gives strokes the same as symptomatic atrial fibrillation. And in many cases, you've already seen it in your clinical practice. If you do cardioversion, if you do ablation, and a patient that was supposed to be asymptomatic, suddenly on the next day the patient said, well, I wasn't asymptomatic. I feel a lot better today. So I personally don't really believe in asymptomatic atrial fibrillation. Maybe in very old patients with comorbidities who don't care whether they have this or that rhythm. But in most of the cases, it counts. It doesn't matter whether it's symptomatic and asymptomatic, and the thing that counts more than symptomaticness of atrial fibrillation is the general status of patient with comorbidities. Okay, so what we can do? We can do pulmonary vein isolations either as using PFA or cryo. There will be a dedicated session concerning PFA today. Or we can do it using 3D mapping systems. As you can bet, this is easier, faster, but this gives us more opportunities because we can also tackle some other arrhythmias, some other re-entrant arrhythmias that are in the atria and improve outcome of the catheter ablation. But generally, at this point of time, we consider in most of the cases equality of those single-shot devices and 3D mapping system-based ablation. So AF and primary prophylaxis. When it comes to observational data, it's pretty clear. These are outcomes of a countrywide database from Sweden, where all patients with atrial fibrillation were included, and it appeared that if the patient had catheter ablation, the outcomes were better. But on the other hand, we have Havana trials, so the biggest trial that was looking at stroke prophylaxis in atrial fibrillation ablation. Well, it doesn't work that much. Why? We all know the drawbacks of the study, a lot of crossovers, very long study because nobody wanted to actually enroll those patients in Havana because atrial fibrillation ablation right now is a cornerstone of atrial fibrillation treatment. So it was hard to actually enroll patients. But I had an opportunity, and still have an opportunity, to be a part of our group that's looking into outcomes of catheter ablation of atrial fibrillation. And we are doing a series of systematic reviews. And this is the outcome of one of those. It's under review right now. And as you can see, the catheter ablation of atrial fibrillation lowers the risk of stroke because there is less atrial fibrillation. And what is important in this systematic review, we only included studies that were conducted during the last 10 years. So more or less, we included studies that actually treated patients with technologies that are available today. So give me a break. Normal point-by-point atrial fibrillation ablation 15 years ago, it was a procedure. It wasn't a treatment. Right now we have pulmonary vein isolation. We have catheters with contact force measurements and everything. It's a totally different story right now. And we have all the single-shot devices. So this is one important thing. And the second important thing is, how do you think? This is the list of cardiological and neurological guidelines or consensus papers, expert consensus papers, etc., dealing with atrial fibrillation. And how do you think, among those documents, how many of them deal with patients with a history of stroke and whether those patients should be treated with this rhythm control or rate control strategy? Pretty basic question for a patient with atrial fibrillation. So how do you think? Who thinks one? Raise your hand. Who thinks two of those documents actually deal with this question? Who thinks zero of them? Believe me or not, 10 plus papers, neurological, cardiological, both sides of Atlantic Ocean and Far East, they don't deal with it at all. So what's the evidence for this? So generally there is evidence. There is evidence, and the evidence is pretty interesting because this is a single randomized controlled study. It's called RAPAS. This was done in Korea, and they randomized patients up to 2 months after ischemic stroke and atrial fibrillation to have either rhythm control or standard care. And guess what? There were about 11 to 12% of patients actually already ablated in this study. So how do you think? Did the patients in the rate control did better, worse, or they didn't care? If I'm showing the study, probably they did better. Of course, and this is the outcome. After only 1 year, patients in the rhythm control group had lower rate of recurrent stroke. So on top of optimal anticoagulation, because they were all anticoagulated, just because they had sinus rhythm, they had less strokes. But what is more important, and this is one thing that my friend who's a neurologist told me, this is more important, the thing at the bottom of the slide. Because those patients who were in the rhythm control group who had better functional status at the end of the observation period. And what do we want to have after a stroke? We want to have patients in a modified ranking scale 0 to 2, because these are the patients who are independent. So that's even more important outcome of this study, is that there are more people that are independent in this group than in the standard care. And this is confirmation of this data, again from Korea. This is a countrywide database showing again that rhythm control started within a year. That was 2 months. This is within a year after stroke, lowers the risk of recurrent stroke. And this is how we try to do it. We implant the implantable loop recorder in patients with ischemic strokes at high risk of atrial fibrillation. We follow up them. And when we find atrial fibrillation, we ablate them. And this is a case of such a situation from one of the hospitals I cooperated with. So what are we waiting for right now? There is an ongoing study, stable, which randomized patients to ablation. And we'll see how it works out, but the way it looks like, they already prolonged the study twice. So we'll see. So ladies and gentlemen, thank you very much. I hope I convinced you at least a little to actually think about patients with atrial fibrillation and history of stroke, that there is a slight chance that they might really take advantage of rhythm control strategy. And we all know that the best rhythm control strategy is atrial fibrillation ablation. And on the other hand, atrial fibrillation ablation lowers the risk of stroke in the primary preference. So thank you very much.
Thank you very much, Dr. Farkowski. So, as you said, we can ablate atrial fibrillation and we can reduce the risk of stroke, even in primary or in secondary prevention. But a lot of studies don't show the same results. Maybe there is conflicting result with us. My question is, do you think that scar tissue ablated with catheter ablation is one of the causes of this non-recurrence of stroke. And do you think that new work technology like can reduce the risk of scar tissue and take more benefits for stroke?
Valid questions. One of them, the first one, is I think that the factor that we are affecting is the load of atrial fibrillation. So patients after atrial fibrillation ablation, they have less time in atrial fibrillation. And we have this outcomes in many studies that the patients with persistent atrial fibrillation, even if they have recurrences, these are recurrences of paroxysmal atrial fibrillation. They are not all the time in atrial fibrillation, how it is in persistent AF. So I think that this is the most important part of this equation that we are actually affecting here with atrial fibrillation ablation. I am a big fan of low voltage area ablation. There is another paper also in the review right now from this group where we looked at the outcomes of catheter ablation of atrial fibrillation and ablation of low voltage areas. And generally, the most important thing you want to achieve when you are doing atrial fibrillation ablation is on one hand do durable pulmonary vein isolation, but on the other hand, if you are doing anything out of pulmonary vein isolation, you should do it properly. So use high energy, pace from the lines you did, pace from the area you homogenized, because otherwise you are preparing the whole new basis for reentrant tachycardias. Whether it improves or not outcome of ablation when it comes to stroke, if you leave this kind of low voltage area because you did a lot of ablation, I don't know. I think that it's valid, it's very interesting, but I can't give you an answer for this. At least I don't know any studies, any evidence directing this or that way. But if you are doing ablation, do it properly, do it with really high energies, and assess what you did. So assess pulmonary vein isolation, assess homogenization, assess completeness of the lines of blood. And regarding your second question, if PFA can change it. PFA, similarly to cryo, makes a little the scar that's a little different from the histological point of view than RF. It's more dense and it's more homogeneous. So again, if you do PFA and you do it properly, so not just around the atrium, but you actually take care of contact, check all the lines of block and everything, I think it's absolutely the same. The recurrence rate is lower, but it's lower in terms of if you do pulmonary vein isolation, but it doesn't translate much to effectiveness of the ablation itself. So probably atrial fibrillation, pulmonary vein isolation is not enough in most of the cases. And I'm personally a big fan of PFA. Right now we are using Farapulse because standards take a lot of time, a couple of months in my center. So next week I'm getting my hands on Medtronic device and on Johnson device. But what we do sometimes when we do the second, third RIT procedure, we do the 3D map, high-density 3D map of the atrium using Carto, and then exchange catheter, and we do applications with Farapulse. Because Farapulse and PFA have different penetration to the tissue, especially the tissue that is a mix of scar tissue and normal myocardium. And we'll see how it works out. But generally, the acute outcomes of such procedures are pretty good. And for example, we had a young guy who had a very big scar in his right, not left, right atrium, probably after myocarditis or something. And he had recurrent reentrant tachycardias. He was
ازاي السيونس دي ولا مش كملوها؟
And then we shoot everything out of this right edge, of course, trying to stay as far as possible from the sinus node. And so far, after 4 or 5 months, he didn't come back. Either he's not happy with the outcome and he doesn't come back, or the auricle didn't come back. Because we have fixed about 3 months period after the ablation that we invite patients for follow-up. And he was at this follow-up procedure, at this follow-up visit, and there was no arrhythmia recurrence. So we'll see how it works out.
Is there any question?
For the secondary prevention of stroke, in the case of the permanent AF, is there a cutoff of the LA area after what we don't indicate the AF ablation? Because we are speaking about AF ablation usually in the case of paroxysmal or persistent AF, but we don't discuss about the permanent AF and the ablation.
But the definition, very good question. It's like a philosophical question, because the definition of permanent atrial fibrillation is atrial fibrillation that is accepted by a patient and a doctor. So the threshold of acceptance might be different between doctors. And for example, for one patient, for one doctor, this patient after 3 months of persistent atrial fibrillation will be already permanent. And I see it, maybe not a lot, but I see it, and I'm sometimes surprised because cardiologists actually do it. And they are telling people that, no, don't go for ablation because they're going to go through your heart, or they make a hole in your heart or something like this. And on the other hand, I'll tell you my take on this. For me, in many cases, the distinction between rhythm control or not, or rate control, is general status of the patient and comorbidities. So it's a balance. If I have a patient who's older, fragile, lots of comorbidities, probably doing cardioversion and then going for ablation won't do much.